Thank you so much, Kelly, for sharing your personal story with us. I'm Joe Greer. I'm one of the planning committee members for the symposium today, and I'm very pleased to introduce our next guest speaker, Dr. Jesse Fann. Jesse comes to us from the Northwest. He is the Director of Psychiatry and Psychological Services at the Seattle Cancer Care Alliance, where he's both a clinician and a health services researcher. And in particular, he's been a real pioneer in developing, testing, and implementing models of care to improve access to mental health care for people with cancer and other medical conditions, including collaborative care. So please join me in welcoming Jesse Fann.
Thank you, Dr. Greer. Thank you, Dr. Irwin. And thank you for the really heartwarming stories. I just want to say it's a real privilege to be here. It's a very unique conference, and I'm just in awe of all the energy and innovation that Dr. Irwin and her group brings. And all we need to do now is clone her a few 100,000 times, and everything will be great. So. I came into this business about 25 years ago, and what I'd like to do is kind of very quickly take you through a journey of how things were and how I think things are now, and really should go forward in what kind of direction it can go. Because as we heard from today's stories, the need is there, but the services often aren't. Let's see. Oops. There we go. Just my disclosures for my research funding and consultation. So the Seattle Cancer Care Alliance is the clinical hub for Fred Hutchinson Cancer Research Center, University of Washington, and Seattle Children's. And I'd like to start with this proverb, because a lot of attention these days is placed on screening for distress, which I think is a really, really important first step. But as we all know, in the pain world, screening for pain didn't always work out so well because we didn't always have a great plan of what to do with it. So I'd like to talk today about what the plan should be once we screen and identify people with mental health issues. We do know from many studies now, and I don't obviously have time to go into all the studies, but we know that screening by itself is not enough because you need to ensure access to evidence-based treatment. And even when you refer a person for treatment, that's not enough, because many people do not actually get coordination and follow-up of their care. And then even if you have co-location or geographically concurrent availability of mental health care, that's often not enough, because you need to track outcomes and really make sure that treatment adjustments are made. As you've heard from the stories today, adjustments need to be made throughout the course of cancer treatment. And if you don't have all these pieces, people fall through the cracks. So this is how things were, and unfortunately how things are often in many cancer centers, certainly not here at Mass General, but in many cancer centers. And this is how it was at our cancer center, where the oncology team identifies somebody who's in crisis, right? So they're not showing up for treatment, or they're in tears, or they're maybe even having suicidal thoughts, and then they get referred in a crisis mode. And when you have this type of scenario, then when you look at the population of patients that you're responsible for, you're only treating a very small piece of the pie. You're only treating maybe a small piece of the people who are in crisis, who have maybe serious mental illness or significant major depression or suicidality, but you're not getting at a lot of people who really could still benefit from help throughout their cancer treatment. And we know from a number of studies now, not just in cancer, but in other medical conditions, that only about a quarter of people who have a significant need for mental health treatment get effective treatment, because many people are not identified or engaged. Many people drop out of treatment, and many people are left on ineffective treatment for too long. We've all heard the stories of people getting put on a medication and then 6 months later, maybe they get a follow-up. So we're very focused these days, and as we should be, on the whole population of patients that we're responsible for. And we call that population health. And we want good population impact. So even if we have a very efficacious treatment, and I think most of the people who get referred probably get decent treatment at many of our cancer centers, but only a small percentage of them actually get reached, and we call that clinical reach. So our population impact is actually quite low in this scenario. Whereas even if you have a slightly less effective treatment, maybe a less intensity treatment because of limited resources, if you have better a clinical reach, you actually have an improved population impact on the population that you're treating. So why do we need this? Why do we even need to think about this? Well, we know that the cancer population is increasing as our population is aging, and we need to, as support people in the supportive care world, palliative care, psychosocial care, we need to keep pace somehow, but with very limited resources. And unfortunately, there's still many what we call silos, where people kind of are functioning in their own little spaces. But these days, we have to really think about integrated care, population-based. It needs to be patient-centered. And we have to think about measurement-based care, where we can't just say, oh, this person looks better. I think he or she's fine. We have to actually measure it and prove it. And so value-based care really is clinical reach multiplied by the effectiveness of the treatment and then divided by the cost, because we don't want something that's too costly that nobody can afford. And we also need to pay attention to patient experience, which is very important given the stress that people are under. So where I think we're moving, and we're still in the process of this, is that we're moving from a purely consultation model to something that's co-located, meaning that we now have services, support services in many of our cancer centers, but they really need to be better integrated to really provide the population-based health that we want to provide for our patients and families. And the collaborative care model that you've heard now from the speakers is probably the most evidence-based. There are now over 80 randomized controlled trials, not all in cancer, but there are now about a half dozen trials showing that this is effective in the cancer setting. And it's population-based, and it really builds on the universal screening mandate that we all have now to screen for distress. And it's patient-centered, and we make sure that it's patient-centered by making sure that we have what we call a care manager that's embedded in the cancer setting to really provide that patient-centered care and to focus on what the patients and families really prefer in terms of what kind of care they get. And that it's measurement-based, that we track our outcomes using validated instruments, and we use a registry to make sure that everybody that's identified with need is tracked and does not fall through the cracks. And that it has to be evidence-based, and we step up care when they need it, but we don't provide intensive care that's costly if they don't need it. And that it's very accountable, it's very transparent, and I think that's important as well. So at our center, we use an electronic registry like the one in the upper left here, and it's color-coded so that when I meet with my team of care managers who happen to be social workers who we train into this model, we can sort their caseloads so that the most distressed folks are at the top, and we can really focus our attention on those. And our care managers are embedded into their clinics, into the oncology clinics, and we use validated instruments like this depression instrument, and then we have now twice a week caseload reviews with the team, and this is a picture of our caseload review. So how this model works is that, of course, the patient and family are in the middle, and the care manager gets a referral or gets sent a patient through screening. And the oncologist is very important in this model because they have to help engage the patient and promote the importance of psychosocial care. And the care manager then immediately meets with the patient, usually within a day or two, and does a full assessment and presents the case at one of our biweekly caseload reviews. And after discussion, they embark on an initial treatment, usually a combination of psychosocial counseling or some sort of brief evidence-based treatment, and possibly a medication that they relate to the recommendations to the oncology team. And many of our oncologists now feel very comfortable with this model, and it may even and feel comfortable starting on, for example, an antidepressant or an anti-anxiety medicine. And then the care manager follows this patient very closely, and if they're not getting better in a reasonable amount of time, they bring it back to the meeting, caseload review, and an adjustment is made. And this is very important because adjustments are often not made to treatment. And then if needed, our psychiatrists and psychologists for the more complex or treatment-resistant patients can see the patient and then communicate back to the oncology team. So this is how the model works, and what I think is our number of advantages is that it overcomes a lot of the barriers that we found in our clinical experience and also in research studies, in that it overcomes the barrier of having quick access, because the care manager is right there embedded in the clinic, and they can very quickly engage and assess the patient. And the oncology team gets feedback not within weeks or months, but within hours to days of a referral. And then treatment adjustments are very quickly made, and we use measurement-informed treat to target. So we always have a target of where we want to head towards with our treatment. And this is very consistent now with the importance of clinical practice guidelines and clinical pathways that we're really emphasizing. And psychiatrists and psychologists, which are more rare and more expensive in the healthcare system than our care managers, are really focusing their in-person attention to the patients who are much more treatment-resistant or complex. And I think it's a really sustainable model because it doesn't replace the usual referral-based model that many centers have, but it really enhances it. And it really takes into account not just the patient's preference, but also the provider's preference. So if an oncologist really does not feel comfortable prescribing a certain medication, for example, a mood stabilizer or an antipsychotic, the co-located psychiatrist, like Dr. Irwin, can still see that patient and do that work. There's now also a billing code for collaborative care, and when we were negotiating this with CMS, we made sure that oncology care was included in the billing process. And if you read the Federal Registry, which is a great cure for insomnia, if you ever want to, oncology care actually is called out as something that's included. It's very consistent with QI practices, and then people really get to practice at the top of their license, and our social workers love this model because they get to do the clinical work that they as clinical social workers love doing. This model is evidence-based in a lot of conditions and settings now. Unfortunately, in the serious mental illness realm, a couple of studies have been more kind of in community mental health clinics providing medical care to those patients, which is very important, kind of providing primary care to patients who generally often don't get good primary care. But I think Dr. Irwin's work is very innovative in providing this type of model in a cancer setting. But it's complex, and I think there are a lot of challenges and a lot of questions that I really think the work here is going to help answer, because the complexity is quite high. Lots of comorbidities, as we've heard from from our panel, but also the medications that we prescribe in oncology care, but also the medications that we prescribe in psychiatry have interactions and have impact on other systems. And then the measurement-based approach to some of these serious mental illnesses are not as well developed as, for example, some of the other approaches for more mild to moderate depression or anxiety, for example. And oncologists, understandably, aren't as comfortable prescribing things like antipsychotics or mood stabilizers. So more education, not just for the care managers, but for oncologists may be needed. And I think the hybrid model, as I call it, kind of a collaborative care model combined with co-location may be the best way. And really leveraging telehealth consultation for centers that are in more rural areas, for example, would be a really innovative approach. And we really need to figure out the best way for our oncology centers to work closely with community mental health centers. So at our center, we have, it's similar size, a little smaller than MGH in terms of, we have about 8,000 new patient treatment episodes a year and over 80,000 visits. And this is a paper that we published back in 2012 that really kind of, we brought together 3 of the folks who've done clinical trials in this area and tried to really map out how we feel collaborative care can be used in this clinical setting. And again, another way to look at it is kind of, along the lines of the theme of this conference, kind of bridging that gap between the oncology team and the psychosocial team to provide evidence-based treatment. This is another way of looking at in terms of our system, our care manager is really at the center, and that coordinates the care and also coordinates with other important support services like palliative care, chaplaincy, et cetera. And we use, again, a stepped care approach to make sure that patients are only provided the intensity of care that's needed. And when they get better, then you'll notice the arrows are bidirectional so that they can step down as well as stepping up. And we make sure that this happens in our caseload reviews. And then finally, just want to say that we, like many centers, we have a network of cancer clinics now throughout the Northwest. Many of them are very rural in nature, and we're exploring telehealth approaches to provide the consultation and expertise that these centers need and don't have access to. So just want to thank many of my collaborators over the years, and also leave with a nice photo of our cherry blossoms in Seattle. Thank you very much.